especially to Professor Purita. And considering that Professor Purita is in the audience, I will start in English the presentation. And I will present to you about hip and spine degenerative disorders and stem cell treatment. Well, so why stem cells? Because in this course here, we've already seen this triangle where we talk about scaffolds like high hyaluronic acid and growth factors like PRP. And what closes this triad is the progenitory cells and the stem cells themselves. Why? They are naturally occurring, present in many tissues, and they do maintain and repair those tissues. And they have the capability of differentiating into a subset of cell types. Therefore, most of them are multipotent. And of course, they have the plasticity to turn a cell into another lineage. And they are self-renewing. When they do replicate later, they produce progenitory cells that will then produce the specialized differentiated cells. Well, I borrowed this slide gladly from Professor Purita. What major types of stem cells are there? There are the embryonic stem cells. We all know our cells come from embryonic stem cells. We have some ethical problems using them therapeutically, and they are always allogenic. You have to borrow them from other cells or from other embryos. We today will talk more about the adult mesenchymal stem cells, adult MSCs therefore, which are the main focus of this presentation. And also, hematopoietic stem cells are interesting to deal because they are in the bone marrow when we draw the blood, and they have some reparative properties as well. Other stem cells, the iPS, they have been induced from differentiated into undifferentiated cells, and therefore they become pluripotential. But this process occurs through viral vectors or enzymatic actions, and their genes might become unstable. There might be some activation of oncogenes, and this is a therapeutical problem. There are more specific other types. There are the V cells, the very small embryonic stem cells that were discovered during leukemia research, I think. Mu cells derived from adipose tissue and bone marrow, and the somatic nuclear transfer cells, which you remove the nucleus of one cell and put another nucleus in, and it's the so-called cloning, like the dolly ship here fits in this category here. Well, I told you I was going to talk more about mesenchymal stem cells. They are also called adult stem cells. They are adherent to plastic, and it's easier for you to sort them, to separate them, and then you can culture them on the plastic. They usually express this cluster of differentiation, which is a protein in the surface of the cells, CD40, CD90, CD105, and they do not express CD34. This is for the hematopoietic stem cell. They repair muscle, bone, cartilage, and tendon. They are autologous. There is therefore no risk of genetic disease, and they are okay to use, says the FDA, if they are minimally manipulated. Well, the origin of MSC is adipose tissue, bone marrow, and muscle, for instance. But we do not harvest them from muscle. We do harvest them from adipose tissue and or bone marrow. And they are their niches, which are associated to vascular structures, and there they might receive the name of parasites. Well, I would encourage you to read this paper, which is a mini review that's for my colleagues at Ortho Region, for that Dr. Arno Kaplan wrote, 2007, Adult Mesenchymal Stem Cells for Tissue Engineering versus Regenerative. And it's a brief overview of these MSCs, where he also shows the progressive differentiation potential from the MSCs that will proliferate and then differentiate into different lineages from bone, for cartilage, muscle, marrow, tendon, and connective tissue, for instance. Well, I told you before, I'm a hip surgeon. Actually, I have devoted my last 20 years for adult reconstruction, which is basically arthroplasty, prosthesis for knee and hip. And I will start with the hip. Well, this is a rather mainstream journal in the orthopedic literature. It's the International Orthopedics from SICO. SICO is a world-renowned society, mainly oriented by the French, I think. And this year, June, these three doctors, they have made a special issue for this journal regarding hip osteonecrosis and treatment with stem cells. And it's really remarkable to see that Philippe Hernigou, or Hernigau, I don't know, his possibly Hernigou, he has been working with stem cells for hip osteonecrosis, AVN, for 30 years. 30 years. It's not recent at all. And here, this fellow here, it's our colleague, he's a Brazilian surgeon. His name is Gildásio Daltro. My colleague here, Otávio, tried to reach him, but he couldn't. He was unwilling, I think. But when we went to São Paulo 2 days ago, Professor Alves told us about his work with 240 patients, but he could not publish that evidence because it was not properly documented. But he has been working along with Professor Hernigou and with his son, I think. Well, 30-year review of progress. He started that in 1985, and he gathered 145 patients, and those patients, 145 hips from 112 patients, and those patients treated with initial lesions, like pre-collapse lesions, he had a follow-up at 10 years, I think, that only 6 out of 145, only 6 needed replacement. And it's absolutely fantastic. And I am ashamed not to know of his work, you know. Well, he published in June this 30-year follow-up of this prospective cohort of 125 adult patients. It was 125 patients were consecutive bilateral cases. They were caused, the AVNs, by steroids, stages 1 and 2, from 1988 to 1988 up until now. They chose either to decompress one side or to decompress and implant MSCs. The follow-up was with physical examination and X-ray, and this is the amount of colony-forming units per implantation, around 90,000. And some patients did get a second implantation 6 months later if they were painful and had low level of cells implanted. Well, and here you can see that when they only had decompression, they collapsed 72% of time. 28 versus 28% preserved when they implanted the MSCs. And the patients decompressed, 76% evolved to replacement, contrary to 24% only. And when they retrieved the heads from the surgical procedure, they said they saw improved repair process on histology. Well, this is just to tell you that there are some other meta-analysis or systematic reviews in the literature. This is a Chinese paper that gathers, looked inside the literature for 7 other papers, showing somehow good results. And there is also this, but this is more anecdotal. It's a case report, a couple of cases, where not bone marrow derived MSCs, but adipose tissue derived stem cells, where they presented a good outcome with those cases. Well, here's not AVN, here is osteoarthritis, and this is a paper from a colleague in Chile, and where it's actually a phase 1 study where he is trying to prove the safety and somehow the efficacy of the method. But here, see, it's bone marrow expanded MSCs. They are cultured. So they have, through their procedure, they have implanted for 3 sequential weeks this load of cells, and they have evaluated their patients average 16 to 40 months later, and you see that the major scores like VAS or modified Harris-Hip score or Vail, they had a very good improvement, but those were only 10 patients, and I will remind you that those were expanded cells. Well, why did we cluster? Why did we gather hip and spine in the same lecture? Because they are, of course, interrelated. To show you that the bipedality, the capacity of walking over only 2 limbs, derived from an alteration in the column. The number of lumbar vertebrae has reduced to 5 or 6, and it has become more mobile. On the quadrupeds, their spine is more stiff in the lumbar area. So it has narrowed the number, it has become more flexible, and it has to link on L5S1. There has to be a broader link, a more stable link, so it has to go up, flex, make an S, and stay there. So this link is more stable. And that's why we have, perhaps, I don't know, so much more problem regarding the lumbar discs in our species, and also hip problems, because you uncover the front part of the hip. And also you have demands for the anterior and lateral muscles to work harder. Well, this is perhaps the most important paper I'm going to present to you today. And this is the work of Petin, and it was published last year. And the foreground is that the US spends annually $100 billion regarding this pathology. 100 billion. This degeneration, however, is universal above 50 years of age. Everybody has it. Well, Phillips, he said, made a systematic review of 26 papers and selected 6 RCTs comparing conservative treatment, which rendered 20% improvement of patients, and arthrodesis, which rendered 35% improvement. Well, I am ashamed. You indicate a surgery and you tell the patient only 35% of you will improve. Well, that's awful. That's what I consider, I mean. Well, and he gathered some other, Phillips, I mean, gathered 12 other studies, and he weighted the average of 43.3% improvement with the reoperation rate of 12%. That's too much. It really is appalling, the results. Well, he gathered 26 surgical candidates. They were referrals for surgery. And he made a prospective, open-label, non-randomized cohort where he aspirated their bone marrows, like 54 cc's, rendered 7 cc's for BMAC, 1 for the exams, and used 6 cc's. 13 patients, he had a single level shot to the disc, like a discography, you know, and 13 patients, 2-level shot. This is the amount of cells he gathered. CFUs 2,702 per cc, and also he measured the amount of hematopoietic CD34, which was 1.66 million per cc, and the results at 3 years. 3 years, it's really impressive. The Oswestry disability index came from 56 to 17, and the visual analog scale from 82 dropped to 21 at 3 years. Well, that's fantastic. You can see the average Oswestry index fall and VAS fall, and it stays stable all along 3 years. And it's, well, he did offer the patients a way out of the study, and he lost 6 patients. He remained with this cohort around 80% for 3 years. But I have to remind you that every patient was a surgical candidate and met the criteria either for artificial disc replacement or fusion. Only 1 of the 6 operated patients of the dropouts who underwent surgery did improve. And here he compared with the literature. Actually, he did some work on artificial discs and did some work on fusion too. And he said that the overall improvement with artificial disc is 57% Oswestry index, and 63 improvement VAS. The fusion is even lower, 43% Oswestry, 52% visual analog scale. And with this paper, he got the result of 71% of ODI improvement and 70 in the visual analog scale. And that's fantastic. And he related that, the patients that improved more, with the concentration of CFU and the presence of the CD34, which is the hematopoietic cells. Well, there are some other, but this is there are some other evidences, like this is from the lab, where he got this is a Chinese paper published 3 years ago, where he got 10 rabbits each group. He put saline, PRP, PRP plus BMAC, and other 10 rabbits as controls, and they punctured their their discs so as to make degeneration, and they used the MRI to confirm the degeneration and the improvement after treatment, should that happen. And they did MRIs at 1, 2, and 8 weeks after treatment, and then sacrifice for tissue sampling. Well, you should see here from the BMAC group plus PRP and the control group that there is a degeneration and there is a later improvement. So they did make it happen so as to form more collagen. And here they are comparable, the controls here, and the BMAC group after treatment. This is the biopsy after sacrifice at 8 weeks. And you see the values of collagen type 2 with the BMAC, PRP, and the control group. So there is a chance of actual regeneration, of producing collagen type 2. Here is just to show you that there is also some research regarding adipose-derived MSCs, but this is not a great paper because it's a phase 1 study and only 10 patients that 6 of them did improve and 3 of them did show some MRI rehydration of the disc. Well, just to summarize to you then, there is long-term evidence for hip AVN treatment with bone marrow MSCs. There are some case reports regarding adipose-derived stem cells, regarding AVN. There is mounting evidence on osteoarthritis. RCTs are on the way. Cohort, Professor Lana himself has one study on the way. There is midterm evidence on intervertebral disc disease, like this cohort of Petin with a single stimulus, one single shot. And of course, there is exciting new technology, scaffolds, 3D printing, tissue engineering, growth factors that are on the way and will certainly help our patients. Those are my boys, my embryonic stem cells I have produced with my wife. Thank you so much for your attention.